Let me just check. Right, so I'm going to keep my video off because I'm trying to share my slides through my kind of FaceTime camera, just to keep the ultrasound clips a little bit more crisp. My name is Gokul. I am an emergency medicine trainee in the Oxford Deanery, currently working in Milton Keynes. I've been using ultrasound for various things for many years now, and one of my favorite modalities is obviously echo. Over the years, I've completed a few accreditation processes and I'm working towards my BSc level 2 at the moment. Um, and mainly, I think my main interest is hemodynamics and critical care, echocardiography. So most of my experience comes from the adult or slightly older children. But we are fortunate enough to have Dr. Sally Hall to talk about pediatric echoes and take you through some of the cases. Um, so briefly, the indications for echo at bedside, as you can imagine, is in cardiac arrest scenarios, children with respiratory distress, when it's not very clear whether it is a cardiac cause or a pulmonary cause, a shocked child, mainly to rule in cardiogenic shock or cardiogenic component, and in obstructive shock like tamponade or severe pulmonary hypertension and RV failure. It can also be used for procedural guidance, for example, draining a large hemodynamically significant pericardial effusion, and which we think in terms of tamponade. And to see if the therapy has worked down the line, people can use it to see if actually the therapy that you've given, the interventions that you've performed have actually made a difference. So it can be dynamic, it can be repeated multiple times. Uh, Important to remember, POCUS is not a formal echocardiography. It's usually quick, targeted scan and basically beginnings to answer clinical questions very rapidly. And with experience, this can be kind of stretched a little bit more in detail with more modalities, more views, and more kind of information from the heart as well as the ultrasound machine. And I must confess, like I said, 99% of the times I'm scanning adults and only sometimes doing like slightly older teenagers. And it's important to note that pediatric echo is not just same as an adult echo because of different physiology and pathologies as the age kind of varies. And it's quite interesting as well. Obviously, we use the phased array probe for mostly for echo. It's low frequency, great footprint between the ribs. But in younger children, it's important to remember that they have higher heart rate and superficial structures. So a higher frequency higher frequency phased array probe might be beneficial as well. And I think of ultrasound generally as similar to taking a picture or photography, because you want to keep the structures and interest in the middle. And you've got trends, you've got the depth button, gain button, and you can play around with this to make sure that you get the best out of your image. Example on the left is an image that is the depth is too much, but sometimes it can be useful. Like in this case, it's a deep plaques view, and you can see that there is B lines in the lung. And that tells you that probably this is a patient with a sick heart and also a wet lung. Whereas on the right side, it's more optimized to the depth of the heart. And that's useful to look at the structures within the heart. Here is an example of an echo where you have the gain is set too high, so it's overgained. Even the blood inside looks a bit echogenic and bright. Whereas in the image on the right, it's slightly more optimized with reduced gain. And I always turn it down just enough so that the fluid or the blood looks black and the edges are kind of sharp and clear for me to see. Right, so just a quick tip on looking at your probe orientation. Obviously, all the other ultrasound modalities, you would have noticed that the probe orientation is on the left. So whatever's left to right on the screen is kind of like left to right on the patient if you keep the probe marker towards the patient's right. And it's quite useful and helpful like that. But in echo, it just kind of flips. So it's important because it's the last thing you want to do is showing off your echo skills and everything is just flipped around and you're making assessment about the RV but looking at the LV, and that can make a big difference. Lots of scanning modes. We won't talk about all the scanning modes, but just briefly, the 2D mode is where you have a black and white image which is moving in front of in the screen. Depends on what kind of slice you're kind of using to get that image. Whereas the M mode is the motion mode, which shows motion over a particular line over time. So this is helpful to look for any structures that are moving over time in a particular on that particular line. So in echo, we use it to look for certain things like mitral valve movements. We can look for the tricuspid annular plane that's called the TAPSE movement. But in lung, you must have used it for looking for like barcode signs and things like that. Color mode, it helps to see flow of color, so the direction and speed. For example, regurgitation jets to assess for stenotic valves. And all the other power Doppler, continuous wave Doppler, tissue Dopplers, all are measuring speeds of either blood or tissue. That gives you some more information. So coming down to the main views. So main views, these are mainly from the kind of the adult world, but also applicable to pediatric echo is the main four views. And in neonates, you might have to use a few more extra views. So you can see there is the parasternal long axis view right in the middle. So it's cutting along the long axis of the heart. You've got the parasternal short axis view cutting along the short axis of the heart. And then you have the apical view that's trying to look for through the apex, but looking at least the four chambers, and then the subcostal view looking at looking from below. And this is mainly because the ultrasound is making 2D slices, but you're assessing a 3D structure. So you want to get as much information as possible looking at different views. And it gets more complicated and more interesting in very, very young children. So quickly slicing the heart along the long axis, so the probe markers towards the right shoulder, somewhere in the kind of the anterior chest, just so it's called parasternal long axis. So it's right next to the sternum, along the long axis of the heart, maybe second, third, fourth intercostal space. And you can see that the RV is usually the most anterior structure, and that's why you hit the RV first, and it's separated by the interventricular septum, separated from the LV by the interventricular septum. And you have the left atrium, the mitral valve, so blood's flowing through the left atrium, through the mitral valve, into the LV, going out into the LVOT, and through the aortic valve out into the aorta. And you can see the RV. It's labeled as RV, but it's actually the RV outflow tract, so just where it goes towards the pulmonary vein. And you have a descending aorta. It's a quite important landmark here in the Sona anatomy, because it helps you differentiate between pericardial effusion, which kind of goes above the descending aorta, and the pleural effusion that goes slightly below the descending aorta. Parasternal short axis view. So you rotate the probe 90 degrees now. So the probe markers towards the left shoulder. And as you can see, again, the RV is the first chamber that you hit. The LV is posterior, so you hit the RV here. You have the RV that's wrapping around the LV, which was in the long axis was more long and kind of cylindrical, but in the short axis, it's round. And it's quite a good view because it tells you a few things. You can look at the heart's pumping. You can look for regional wall motion abnormality. You can look for the RV size and see if the septum is kind of behaving normally or whether it's pushed into the LV because of more pressure at the RV. Obviously, the short axis can be done at different views. So here, the first view that we saw was right at the middle of the LV. So you see the papillary muscles. But if you slide that up the chest or aim it slightly higher up, you're at the base of the LV. So you get the mitral valve in the middle. And right at the top where the great vessels are, you can see the aortic valve and also sometimes the pulmonary valve. So as you can see here, it's fanning through the heart at the base now, where you have the mitral valve, then fanning more papillary muscle all the way to the apex. So just by one movement, you can either do this by just tilting the probe or fanning the probe, or actually sliding down the chest. Right, so obviously, the most important kind of view sometimes is the apical four-chamber view. It's a great view to assess for the size and function of the different chambers of the heart. And the probe is placed at the apex beat, and the pointers somewhere between 2 and 3 o'clock, looking up along the axis of the heart. The chambers of the left on the left are the right ventricle and the right atrium, and the chambers on the right side of the screen is the left atrium and the left ventricle. The left ventricle is usually slightly more muscular, whereas the RV is slightly more thin-walled. But actually, in very young kids or at birth and neonates, the RV might be the more dominant chamber. So it might be as big as the LV. It might be also as thick as the LV. But as we grow older, the pulmonary pressures are lower, so the RV has to kind of work less hard as compared to the LV. And we also have the descending thoracic aorta on the left side. But it's usually we tell everybody to look between the ribs so that you can see the heart. It's like the small window between the ribs. But actually, when you start to do that in slightly older kids who've got ribs which are more kind of more opaque on ultrasound, you basically see this. And that's mainly because you're just looking up into the chest in that intercostal space, but you're actually just looking at the rib. So one way of overcoming that is basically riding onto the lower rib and slightly looking up through that gap. And that's quite useful when you're just starting off as a novice. Something about foreshortening, just a quick mention. So it's quite possible that you can make the structures look a little bit bigger or smaller depending on how you cut the heart. So if you see in this, when you start off, the LV looks a bit round, the RV looks a bit big. That's because you're not at the apex. But when the probe is moved right at the apex, the LV is more bullet shaped. The RV looks like its normal size in this adult kind of heart. And just to bear mind about LV foreshortening when you have an image, just making sure that you're actually at the apex. And this is a common mistake that we see normally when you start off scanning. In neonates, you might have seen these kind of inverted images, and that's basically the same four-chamber view, just inverted. So this is mainly to keep the anatomy as is. So the atria are at the top and the left ventricle and the ventricles are at the bottom. It helps to understand what's going where, what's connected where, and if there's any kind of defects to understand anatomically for the pediatric cardiologists as well as the pediatric surgeons. Again, chambers on the right side are the left ventricle, left atrium, and chambers on the left side of the screen are the right ventricle and right atrium. And I know that because of the descending aorta on the left side. Right, the last view. So that's your subcostal view. The probe marker is on the 3 o'clock direction and mostly in the midline or just below the costal margin on the right side. And you're looking or fanning up into the chest to look for all the four chambers. And you can see all the four chambers of the heart in the subcostal view. And when you turn the probe like 90 degrees, you can actually then start to see the IVC emptying into the right atrium. And this is quite useful as well in kids because you want to see whether the vessels are emptying where they're supposed to look for any kind of congenital abnormalities. And obviously, you must have heard that everybody looks at the IVC as like a golden marker for fluid responsiveness or fluid tolerance or fluid status in some case. But I don't regard it as a fluid status. I regard it as something that's connected to the right atrium. So it reflects what's happening in the right atrium. So it's a kind of a marker of the right atrial pressure or the central venous pressure. But it's quite useful. It can help you kind of categorize shock into a few things. So like low CVP shock and high CVP shock. And that helps you kind of narrow down what kind of shock and what therapies might be useful. So low CVP shock like hypovolemia, distributive and neurogenic, whereas high CVP shock in some cases with cardiogenic shocks and obstructive shock like tamponade. I've not mentioned septic shock here because septic shock can present in any phenotype depending on whether it's distributive, vasoplegic. Sometimes it can develop a cardiogenic component to it. So it's about putting the whole picture in and the clinical context and everything that you have in clinical examination in one place and then making an assessment. This is an example of a normal heart. So you've got the plaques view, which is the parasternal long axis view, and you can see thickening of the left ventricle, and it's coming closer, and the LV cavity reduces with each beat. So this is a normal functioning left ventricle in the short axis view, whereas this is in the apical view. So just eyeballing this basically looks okay. Whereas this patient, it looks quite hyperdynamic. You can see that the chambers are almost kissing the papillary muscles in this view, and the LV looks quite, it's tachycardic, but also pumping quite a lot. So the ejection fraction is quite high. This could be hypovolemic. This could also be a very low afterload state. Whereas this is what I think echo mainly helps us kind of differentiate and pick up quite early, because the therapies are quite different for these cases. And this is a really sick heart. As you can see, there's hardly any contraction. Both the LV and the LA look very dilated. And then you can see the mitral valve is just about closing. So there might be mitral regurgitation as well. And actually, if you look beyond the heart, the lungs are wet. We've got lots of B lines. So this is a patient in shock, cardiogenic shock, with a very wet lungs, so in pulmonary edema. And this is where echo plays a key role. Just to mention about the right ventricle, because it's not as easy as the left, because we've just seen about the left ventricle. The right ventricle is quite complex. It has a special kind of shape in geometry, and it can be affected by multiple things, including like acidosis, hypoxemia, and hypocapnia. So all of those things can cause changes in the way your RV functions. And the RV shape is more like it wraps around the LV, and it's made up of like circumferential kind of fibers as well as longitudinal fibers. And that is what we assess, but it's very hard to assess the RV function, even in adults, on echo, because you're only looking at two kind of functions, but you're not imaging all of the RV. And they've started using 3D echo to assess for anterior-posterior motion, as well as the radial and longitudinal motion. But that's not something that we can do at bedside. So visual assessment about the size and function is quite limited. Normally in adults, you'll see an RV that's about probably 60% the size of the LV. But at birth and neonates, the RV will be quite dilated, or maybe as the same size as the LV or slightly bigger. And in congenital diseases, it might be even more bigger if you've got raised pulmonary pressures. So eyeballing is useful, but not very useful in pediatrics.
Price to earnings ratio tells you how much investors are paying.
And RV function, so mainly you can see that the RV functions by going up and down, that's the longitudinal motion, and coming towards the septum, so that's your radial function. So that's what we're assessing. We are assessing for a longitudinal function, looking at this annulus, whether how much it's going towards the apex. And then we are assessing the radial function, which is the how much the lateral wall or the free wall is coming into the septum. And also septum provides some of the contraction for the RV. People use TAPC to look for the longitudinal function, and it's by putting the M mode along the lateral annulus, and you get this trace over time. So this is each beat, your lateral annulus going up and down, and you measure from the bottom of the top of one of those bright lines, which represents the annulus. It's useful, but not very useful in very young kids, because what's a normal TAPC? It's very hard to say. It changes with age. But in adults, we keep it as more than 2 centimeters as probably normal, and less than 1.6 as probably abnormal. But it's not always the best marker for RV function. So here is an example of a unhappy RV. You can see the Plex view. The LV looks okay, it's hypertrophied, but the RV is quite dilated, the RVOT basically. And here you can see that the RV is very dilated and it's pushing the septum right into the LV and forms like a D shape. This is called the D sign. What this suggests is the pressure in the RV is higher or is raised, that it maintains the septum push towards the LV. So this is a pressure overloaded RV state. And same thing, it can be seen here, very dilated RV. Trabeculations are more obvious now, and that's because it's stretched, and the radial function is kind of very poor. That's what's shown here. I'm going to skip through tamponade. Just to mention is, obviously, the first step in finding out a tamponade is pericardial effusion, and that's what you can see here. There's large pericardial effusion here. And what this is basically showing you is when the mitral valve is open, you can see the RV is collapsing. So when the mitral valves are open, the ventricles are meant to fill. but the pulmonary pressure, the pericardial pressures just overcome that and overwhelm the RV, and the chambers collapse. And this is tamponade physiology. Same thing can happen in the atria level. So you can see here that the atria is collapsing when the tricuspid valves are closed. So the atria is collapsing when it's meant to fill. And that's also a sign of possibly tamponade physiology. Obviously, correct tamponade as a diagnosis would be clinical. When I say clinical, it's about your blood markers, your kidneys, your other parameters and hemodynamics, and also echo. But the first step is by finding out if there's a pericardial effusion. And for that, bedside echo is great. Right, but in neonates, it becomes very complicated. So in neonates, you're in the subcostal view, you're also looking at the organs to see if the situs is in the correct place. So this is the liver on the left side, and the IVC on the left, and the aorta on the right. So yeah, that probably is in the correct place. And then you can trace that IVC and the aorta to see if the IVC empties into the right heart. This is a right ventricular inflow view where from your parasternal view, you just fan the probe. So you're aiming towards the right hip of the patient, and it brings up the right ventricle and the right atrium. And it's useful to look for tricuspid regurg, to also look at your tricuspid valve and any anomalies with that. And this is just the opposite way. So now the tail is facing towards your patient's right hip from your plaques view. And then that brings up your pulmonary artery as well as the pulmonary vein. And that's where you can put some color slightly higher up in the chest to look for any PDA. And you can see in this image, no, it's not playing, but yeah, you can see a flame that's going up. That's going up, so that's towards the probe. So that's going from the aorta towards the pulmonary artery. So this is a left to right shunt. Whereas probably somewhere here, you can see a bidirectional. So it's red and blue. So it's going in both directions. So that's just a quick view of the different views and what you can do with echo and what basic things you can probably see in the bedside. But for the main course, I'll hand over to Sally, who's going to talk about a few cases and obviously correct me where I've gone wrong so far.
Hi, thanks for that. So I'll just work out how to share my screen. 2 secs. Sorry, computers are not my strong point.
That's all right, take your time, Sally. Did anyone have any questions for Gokul about any of that, any of the views, or did anyone have any questions, shared experiences, anything like that? No? Okay.
Super. So so my name's Sally. I'm one of the paediatric cardiologists working in Leeds. My interest is in advanced echo. So the sorts of echoes I do are detailed echoes, not quick answers to questions. But I've tried to sort of do this talk based on sort of the assessments that we do of children in sort of an accident emergency department, sort of a sort of critically unwell child, and just sort of go from there. So I'm going to talk briefly about the basics of pediatric echocardiography. Gokul's covered a lot of that, so I'll just flick through it quite quickly. I'm going to talk about what an echo can and can't do. And then the main part of the talk is going to be sort of case studies and examples. So first of all, echo basics. So echo is obviously ultrasound, and we use probe, and the probe has a footprint, which is the red or sometimes grey square at the end of the probe, and that contains these things called piezoelectric crystals. When the crystal gets a electric impulse to it, they change shape, and that creates the wave that travels through the tissue. Tissues of different densities reflect different amounts of the wave, and so we can then use that to create the image of whatever it is we're looking at. As we've mentioned, bone reflects 100% of the beam, so if you put your probe directly onto someone's bone, you won't see anything through it. And so that creates a problem when looking at the heart, because the heart is trapped inside this cage of bone, So there's only usually these 4 main windows that we can look through. So unlike if you're scanning someone's abdomen, it's nice and squishy, there's nothing in the way. With the heart, it's very restricted. But also the lungs obviously contain air, which scatters the ultrasound beams, so the lungs get in the way as well. So the views that we like to use, so the first one's a subcostal view. So basically the sort of highest squishy point in the abdomen is what I think. So just at the point of the xiphisternum, you basically need to push in and look up. And in pediatrics, we always invert the image because we want to look at things the right way around. We don't, you know, why would you want to look at an upside down picture? It just doesn't make sense to us pediatric cardiologists. It's an excellent view in neonates because there's no bones, no lungs in the way. But in larger patients, it can be problematic because it can be a long way from the heart. And also in kind of your subtoddler age patients, it's really quite uncomfortable. So often it can be quite challenging in them. The apical window, the probes over the apex beach, which is usually somewhere around the 4th or 5th intercostal space. However, one of the problems in pediatric cardiology as opposed to adult cardiology is that things can be in completely different places. And, you know, we're often the first point of contact for children with very complex anatomies. And although Gokul was talking about left things being on the left and right things being on the right, that is not how pediatric cardiology works, unfortunately. So first of all, the heart might be in a completely different place, and that might be due to the heart being in the wrong place for itself in kind of dextrocardia, or other things shifting it over. So in the case of diaphragmatic hernias or pneumothorax or whatever, the heart might have just shifted. Whatever the anatomy, we want to keep the marker at 3 o'clock so that all the probes have like a little line on them that corresponds to the marker that comes up on the screen, so that we know that things that are on the left of our screen are on the left of the patient. And by left of a screen, I'm talking about as you look at it, the right. I realised the other day that my lefts and rights are always completely reversed because I'm always talking about the patient's left, not the left I'm looking at. Really confused a plumber when he came to look at my tabs. So apical views just tend to be better tolerated by children, but you get a lot of lung interference, and you can get around that by putting an older and more sort of compliant child on the left side, and if they're able to, sort of timing respiration with them as well. Parasternal views, so as we've already said, we've got the long axis and the short axis. But again, it's very much dependent on if the heart's where it's meant to be, and it might not be. It's a good view because it's close to the heart, even in large patients, and the younger patients tend to tolerate it better. But again, you've got the issue of lung interference. And then we've got what we call the suprasternal window, or the arch views. So basically the squishy bit at the top of the neck. Put the probe in there and look down. You might need to downsize your probe just so that it'll fit into that view, into that space. You get good views of the aortic arch, your branch, pulmonary arteries, and basically everything above the heart. But it is very uncomfortable and poorly tolerated by awake children. And even older children can struggle to tolerate that. So what can we use an echo for? So it can complement clinical examination to diagnose congenital, acquired, and post-operative pathologies. We can use it to guide ongoing management, but there's also things that an echo can't do, and this isn't meant to just be an all-round moan about what not to ask for an echo for, but just to kind of, say an echo isn't be all and everything. An echo can't save lives. So do not delay life-saving treatment, stabilizing treatment whilst you're waiting for the cardiologist to come and do an echo. You know, if you've got a desaturated patient, give them oxygen. You know, if you've got a patient that might be septic, give them antibiotics, get access. The echo isn't going to save the child. It might point you towards the direction of the condition that you need to treat to save the child, but it is not the life-saving treatment. It can't always tell you exactly what the cause of the condition is. So obviously Gokul also showed us some pictures of very poor function, but what we don't know is that function poor because the patient's sick, or is the patient sick because the function is poor? We can look for other signs that can give us those answers, but sometimes, you know, the only thing that's going to tell us is, you know, time and what happens with the patient's course. It can't reliably assess filling status except at extremes. So, you know, we can get a lot of requests. What's the filling status? What's the filling status? I can't tell you. If the patient's massively overfilled, then we're going to see a dilated heart and a dilated IVC. If a patient's massively underfilled, we're going to see empty things. But at the same time, if the patient's massively one way or another, you should be able to go clinically. You know, I can't tell you small changes based on an echo. I also can't immediately tell you the response to most treatments. Now, there are differences to that. If you're going to drain a massive pericardial effusion, then I'm going to be able to tell you whether it's worked or not. But if we start some, you know, milrinone, for example, for poor function, in a few hours, in, you know, tomorrow, whatever, I might see an improvement. But having started that infusion, we're not going to straight away see an improvement in the echo. And often what you see is an improvement clinically before we see changes on an echo. And as cardiologists, we don't scan things that aren't the heart. I'm sorry, I don't. So I can't look at things outside the heart, and that includes position of the blinds. Now, other people, radiologists, people that are using ultrasound, absolutely can do these things. But as a cardiologist, that's not something that is, unfortunately. And I also can't perform a detailed echo in 5 minutes. I might be able to answer you a quick question in 5 minutes, but again, depending on the clinical scenario, I can't get you, you know, all the answers in 5 minutes. And as well as this, there are patients that aren't suitable for an echo. So first of all, patients whose chest we can't get to. So if they're prone, I can't do an echo. I need to get to their chest. If there's machines in the way that mean I can't get what is actually quite a large machine into the patient's bed space, I can't do an echo. If the patient's covered in dressing, so I can't physically get the probe on them, I can't do an echo. Patients that are very distressed, really upset children, unfortunately, you know, I can put a probe on, but beyond telling you that the heart's moving, I often can't tell you more. But also patients that are extremely unstable, as we've said, echoes take time and they take pressure, and patients do become destabilized by echoes. And, you know, I have had a baby die in the middle of an echo because it was that unstable that it just couldn't tolerate it. Now, I don't want to say that baby died because of me or because of the echo. You know, it was a very, very sick baby. But, you know, it was the thing that finally tipped it over. Patients with an unsafe airway. So to get the views, we have to move the neck and we have to move the patient. If you've not got your ET tube in a good, safe position, then there's always the risk of it being dislodged during the echo. So make sure any airway issues are sorted, because, yeah, I always say the first rule of echo is if you accidentally extubate a patient, make sure you can blame someone else. Right, so I'm going to move on to the cases now. So I do want these to be interactive, so please do shout out. I can't see the chat or anything, so please, if anyone, when we get to some questions or anyone wants to sort of say anything, please do shout out. Don't sit in silence, because otherwise I feel very lonely. So these are all patients that have come in through A&E departments within Yorkshire who I've been involved somehow in the management of. So we'll start with case one. This is Arthur. He's 4 weeks old, but he was born prematurely at 35 weeks. He's a twin. His sister's called Edith. And he was, at birth, he was weighing 2.2 kilograms, and he's now barely over 2. For the last 2 weeks, he's been much quieter than Edith, and he's just not regaining his birth weight, whereas his sister's just piling the pounds on. This morning, he was unsettled. Parents thought he looked quite blue. They called 999, who obviously went out, assessed him, and thought it appropriate to bring him to resus. On arrival, he's pale, he's mottled, his saturations are 50%, and he's fluctuating between being very, very quiet and being very, very distressed. So you examine him, his heart sounds normal, he doesn't have a murmur, he's got good femoral pulses. But you give him oxygen, his sats improved to 80%, so still not normal, but they've picked up. and he's now got a really loud murmur. So this murmur that wasn't there suddenly appeared. And these are his echo pictures, which I'll just let you have a look through. I'm afraid some of them are a bit jerky, and I don't really know why. So what I'm going to do is move on to the questions, and then we'll come back and have a look at the pictures and talk through what they show. So first of all, does anyone want to say what the diagnosis is?
Sally, could we just go back to the images while we're thinking? Is that all right?
Absolutely. Oh, no, clicked one too many, sorry. Say computers are not my strong point.
Yeah, there's a hand up in the chat. Go for it.
Hi, Sally. So we have to think cardiac and extracardiac causes.
Yeah.
So in the cardiac, I would like to think that, I mean, from the echo images, it looks like there is a high velocity jet across the pulmonary valve.
There is.
Yeah, and there is also some turbulent flow. So most likely right ventricular hypertrophy as well. So I'm thinking of critical pulmonary stenosis or TOF. Both will present with cyanosis and improving partially with oxygen. And now you also mentioned about some ejection systolic murmur. So those will be my differentials. Yeah, and
Great.
yeah.
Yeah, super. So I'll talk you through the echo pictures now, but you know, good answers. So the first echo that we're seeing is we've got the left ventricle and the right ventricle, and this is the ventricular septum. And what we can see is a hole. So this patient's got a ventricular septal defect. So there's a hole sat between the ventricles. There's then a big vessel leaving the heart, which I will tell you is an aorta. And that's sitting above that hole. So it's doing what we call overriding. And as you say, what we can see going through the pulmonary artery is turbulent flow. And if we can come to the short axis, what we're seeing is a big chunk of muscle sitting in what we call the RVOT, so the right ventricular outflow tract, next to that VSD. So this is what we call anterior deviation of the outlet septum. So the outlet septum is the part of the ventricular septum which sits between the aortic valve and the pulmonary valve. And when we have anterior deviation of it, it moves forward to sit in the RVOT and causing what we call infundibular pulmonary stenosis. So this is narrowing of the RVOT below the level of the pulmonary valve. And this, as we've said, is consistent with tetralogy of Fallot. So we've got the VSD, we've got the overriding aorta, we've got the infundibular pulmonary stenosis. And as a result, if we left this child, his RV would become more and more and more hypertrophied, and that completes the 4. This is a Doppler trace, so this is measurement of the velocity going across the pulmonary valve. And I don't know if you can see, but there's kind of 2 traces. So there's one that's nice and round, like this, but then there's one that's also more dagger shaped. And this is what we typically see in tetralogy of Fallot. We call it a fixed, so that's the round one, and a dynamic, and that's the dagger one, component. So the fixed component tells you what the obstruction is across that valve at all time, but the dynamic component tells you that it's a muscle obstruction, because as the flow is leaving the ventricle, that obstruction is getting more and more tight because it's muscle and the muscle's contracting, and so you get this kind of two signal appearance of both the fixed and the dynamic. So this is typical for tetralogy of Fallot. So does anyone want to tell me what the immediate management of this patient is? The baby's in A&E, SATs of 50%, blue, the fluctuating level of consciousness, Does anyone want to give a baby any management at all? Again, shout out because I can't see if you've got hands up or anything.
And besides ABC management, prostaglandin E would be one definitive management.
Okay, so what part of your ABC management is extremely important in this baby? Like, yes, you'd do it to any baby, but what am I thinking of is actually a part of this management? So sorry, I probably should have sort of specified that yes, this is tetralogy fallow, but it's a tetralogy fallow baby that's having an acute spell. You know, they are at the point where, you know, they're very cyanosed, so we need to jump in and do something. So one of the parts of your ABC management will actually help relieve the spell. And does anyone know what that is?
Is it correct?
And morphine?
Sorry, what was that?
Oxygen and morphine? I know that
Absolutely. So
two
I'm
things
thinking
between
oxygen. Oxygen's kind of the first part of the kind of the ABC management. Absolutely. So oxygen works as a pulmonary vasodilator, so we'll drop the pulmonary pressures and increase the gradient across that obstruction. So just like if you had a ball on a ramp and you increase the angle of the ramp, the ball will roll faster. Decreasing the pulmonary vascular resistance will make that gradient steeper. And so even if you've got some obstruction, you're gonna help get blood. And then, as you say, morphine to get help relax that muscle and also help relieve the pain. So crying puts your pulmonary pressures up. So a spell is apparently very painful. I've clearly never had one myself, but you know, it's said to be very, very painful. So these babies cry a lot. But by crying, they're increasing the pulmonary vascular resistance and decreasing the blood flow across the obstruction. So they get into this spiral where they're distressed. So they cry because they spell, and it just becomes sort of, you know, a self-perpetuating loop of badness. So yeah, prostin. So tetralogy fallow isn't truly a duct-dependent defect, but absolutely, I wanted to start prostin on this baby because if I can reopen his ducts, he didn't have a duct at this point, then there will be more. Then there's another source of blood flow to the lungs. So absolutely, prostin. And the other thing you've got to think about is this is a collapsed neonate. And yes, we now know the diagnosis is tetralogy fallow, but you know, something's triggered the spell. And so always think of, you know, do you need to give the baby antibiotics? And the other thing that goes with treatment of spell and treatment of the collapsed neonate is a fluid bolus. So again, gives the baby fluid and a good 20 per kilo to push the fluid, push the blood across that obstruction to get to the get across the obstruction and help relieve the spell. And this is one of my points about the echo itself can't save a life. So I got, this was a case from quite a few years ago now, but I got a call as the paediatric cardiology registrar from the A&E doctor saying he had a baby, he thought it was cardiac. And I was like, okay, have you called paediatrics? You've got a collapsed neonate. No. What have you done? Oh, we've given the baby oxygen. Have you done anything else? Have you got access? No. Right, well, call the paediatric registrar. I will come down, but I need to go and get the echo machine and everything. You know, it's going to take me a bit of time to come down. So I got down to A&E, and yes, they'd called the paediatric registrar, but she'd just joined them in standing next to the baby. And this baby in A&E was sat to 50%. Someone had put an oxygen mask on it, but apart from that, no one had done anything. They just stood there and waited for me. And, you know, regardless of what this diagnosis was going to be, the baby was going to need IV access. You know, it needed bloods. It needed antibiotics. Don't just stand and wait for an echo. Do other things in the meantime. It's just my little bugger. So yeah, how much of this could have been established without the echo? Most of it, really. Right, here's a question for the gold star for the point. Why, when the baby come in, was there no murmur, and then once they gave oxygen, the murmur appeared?
Very little outflow, so there was no blood really going anywhere.
Absolutely, absolutely. So initially the baby was having a spell, and that muscle was in so much spasm, it had completely closed off all the outflow. So the reason you get a murmur is turbulent flow. If there's no turbulent flow because the outflow has sealed itself, there's going to be no murmur. So that's something extremely important to know. If you've got a child that you know has got tetralogy of Fallot, comes in very blue, and you listen and they've got no murmur, you don't need an echo to know that that baby is having a spell. You know, you treat that as a spell even before you can get the echo on them. So yeah, management. So he was given 100% oxygen, initially by a face mask and then intubated, just because of the general instability of the baby. Prostin, as we've already said, to try and get a second route of pulmonary blood flow. IV morphine, try and relax the muscle, try and relax the baby. A fluid bolus to push the blood through. Antibiotics, because we've got a collapsed neonate. And then he was transferred to the catheter lab and had an RVOT stent on ECMO. Now, the reason it had to be done on ECMO was that when you do an RVOT stent, you have to occlude the RVOT, and in an already unstable baby, he actually arrested the first time they tried it, got him back quite quickly, then put him onto ECMO to do the RVOT stent in a more secure view. And these are just pictures of this RVOT stent sat in the narrow RVOT with good blood flow now going into the branch pulmonary arteries. I always think stents look a bit like wheat crunches. I don't know, maybe I'm just hungry. But yeah, so we've now got the stent, and the way the stent works is it holds that muscle open. So even if the baby, you know, tries to spell, that outflow can't contract, and you get this nice, you get this outflow. Now, obviously, babies grow, stents don't. So over time, they can grow muscle around the stents, and muscle can grow at the entrance of the exit to stent. So if a baby comes in with an RVOT stent, it is still possible for them to spell. So if they're coming in with symptoms of spell, don't think, well, they've got an RVOT stent, they can't spell. Muscle could have grown around it. And that's because this isn't a definitive treatment. It's a palliative treatment to help get the baby to a point where they can have surgery. So I'm going to just talk briefly about echo assessment of the acutely blue baby. So the goal is to identify why the baby is blue. So the right treatment, treatment can be directed, I should say, rather than initiated. You should have initiated some treatment even before the echo. And then we can get the finer details later once the baby's stable. So causes of severe cyanosis identifiable on echo. So we've got TGA, we've got pulmonary atresia or critical pulmonary stenosis, tetralogy of Fallot that we've already talked about, TAPVD, so anomalous pulmonary veins, PPHN, so a non-cardiac diagnosis, and in babies that have already had a procedure, a block shunt and a block stent is something very important to think about. And the good thing about these is subcostal values in a neonate will give you most of the answers. But don't forget to assess the atrial septum and assess the pulmonary veins. So here we go. So at the top of the screen, what we're seeing, so it's a bit of a sweep through, but we're seeing two great arteries coming off of ventricles in parallel. They're not crossing over. So that's a sign that this baby's got TGA, and actually what we see is the vessel from the right ventricle is going round in an arch, whereas the vessel from the left ventricle is splitting into two. So we've got an aorta coming from the right ventricle and a pulmonary artery coming from the left. Pulmonary atresia, we've got no flow coming out of the right ventricle. And what we can see up here is that they've got a duct which is coming in and flowing, filling the pulmonary arteries via the duct. Tetralogy, we've already talked about. TAPVD, what we're seeing is a right to left shunt across the atrial septum. So this is, it's not only TAPVD that causes this, but when you've got a right to left shunt, you always, in a blue baby, you need to assume it's TAPVD until you can prove it isn't, because TAPVD is something that will make a baby very sick very quickly and needs immediate surgery to correct. Right, we'll move on to case 2 now. So Adam's 4 years old. He's got a background of an undiagnosed metabolic condition, but he's actually usually quite well. He's got a few issues with his eyesight and things, but his normal health status is quite good, but he's now got a 2-week history of fever, tachypnea, and just becoming increasingly lethargic. He was seen in A&E a week ago, where they examined him, thought he had a chest infection, so sent him home with oral antibiotics, but there's been absolutely no improvement, so Mum's brought him back. So the initial observations, his respiratory rate's up, his saturations are okay, he's a bit tachycardic, he has got a temperature, so, you know, basically his other obs could just be explained by being febrile. And he's really miserable, but, you know, Mum can kind of keep him calm. He's hot to touch, he's got a temperature, as we said, his chest is clear, he's got some subcostal recessions, so some increased work of breathing, and you really struggle to hear his heart sounds. And then this is his x-ray. Does anyone want to comment on the x-ray or the clinical sitch?
Yeah, we've got massively increased CTR, haven't we? Occupying most of the sort of hemithoraces.
Yeah.
Trachea looks vaguely midline, but hard to tell, isn't it? You can't make too much else out about the lungs, I don't think.
No, absolutely. But I mean, it's a massive heart, isn't it? So what sort of things are in your mind that this could be?
Something that's led to like an RV hypertrophy over time. So could obviously be kind of.
It's quite in a short-lived history, but yeah.
I guess back in my mind, sorry, I was assuming that the metabolic condition, which was undiagnosed, was this all along manifesting as a cardiac thing. Sorry, I might have jumped the gun with that.
I think you have. I'm sorry. Yeah. So the things that are on my mind is a big heart, and the thing that would go along most with that is a dilated cardiomyopathy, really, or a pericardial effusion.
Yeah, I was going to say, can it be effusion or tamponade?
Absolutely. So he had an echo in A&E, and they saw this. Anyone want to say what that is?
Absolutely enormous effusion, biggest I've ever seen.
Isn't it? Yeah. So yeah, an absolutely ginormous pericardial effusion, and like it's a long time since I've done adult medicine, but I don't think an adult with this effusion would come in just a little bit miserable. I think they'd come in like almost dead. Kids are remarkably resilient, you know, having major things going on with them and still watching Peppa Pig, and just taking everyone by surprise. So an absolutely huge pericardial effusion with some right atrial collapse, some right ventricle collapse. So we have got evidence that, you know, the heart is struggling to struggle, but the kid's actually quite stable with it. You know, like, yeah, his obs are out a little bit, but nothing's changed majorly. So what's the diagnosis? A massive pericardial effusion with some evidence of tamponade. And the management is pericardiocentesis and drain insertion. And I'm just making the point of not diuretics. So if you give this heart diuretics, what you do is you remove all the fluid that's inside the heart without removing the fluid around the heart, and also what's like got evidence of a little bit of cardiac compromise at the moment becomes an arrested child. So for smaller effusions, we might treat them with diuretics just to try and get rid of the fluid. But when you've got a big effusion like that, do not give diuretics. And then the other question we had is the urgency of this drain. So this child's at a peripheral hospital. Are they safe to come to Leeds? And we decided actually, yes, they were, because their clinical status wasn't changing. We wanted them moving by the children's transport team, you know, absolutely not in the back of a car with mum and dad, although that was how it arrived at A&E like an hour earlier. But, you know, we decided to come to Leeds, get the team in and get this done professionally by a interventionist rather than a have-a-go hero. But it was a bit of a, you know, a decision to be made, because the picture is terrifying and the child is not well, but, you know, is clearly coping. And actually, when he had it drained, he had over 1.5 litres come out of his pericardium. So this kid on arrival in Leeds weighed 17 kilograms, and when he left was 15.8 kilograms. So was walking around with like a significant proportion of his body weight being pericardial fluid. So echo assessment of a pericardial effusion. So it's a massive black space going around the heart. Subcostal views tend to overestimate the size, but it is the view that the interventionists want to see to know whether or not they can get it to drain. Look for evidence of tamponade. So as we said on the other one, we could see the right atrium collapse. So there is signs. You can also use pulse wave Doppler of the mitral and tricuspid valve inflows to look for signs of compromise. So if you reduce your sweep speed right down so you get more signals on a screen, you can see when the patient breathes out, it goes up, and when they breathe in, it goes down. And this sort of, if you're getting more than 40% variation, that suggests compromise. So these are pictures I've had to lift from online. I couldn't find them. And the other thing is there any fibrin strands? Are there loculations within the effusion? So these like strands, this isn't too bad, but sometimes there's loads in it. And then, you can stick a needle in that, but actually you'll only drain the bit that's got the needle in it. Do they need to go for sort of a more surgical approach? And it always needs to be differential in a patient presenting post-cardiac surgery, and especially an ASD closure. So patients that have cardiac surgery have effusions, have tamponades. So always a sort of differential for those patients presenting that, aren't quite right. And unfortunately, in ASD, which we think of, pretty much the most straightforward cardiac surgery we do, they are the patients that get this. So if you get a patient coming in post-cardiac surgery who's not quite right, get a chest x-ray, always consider, could this be effusion? So
Sally, can I just ask a quick question? Is that all right?
Yeah.
Sorry, it's just on your previous slide. If you were to go back, I was just going to ask about the mitral velocity and flow variation, and you obviously talked about it. I've never done it in real practice. I just haven't had, loads and loads of sick cardiac babies to echo, to be honest. But I've obviously been shown how to do it, and I've done it before. Across this variation, I'm sorry, I'm pointing with my mouse, which you can't see. Does it have to be a kind of consistent change in reduction of velocity, or can it be kind of 1 or 2 times, which is, it's very variable on your graph in terms of that velocity change? Can it just be intermittent? Would that still qualify for?
So it's usually consistent. Stuff that's variation in children tends to be more they've moved out the way, or they've cried, and that crying makes it bigger. So you usually get this consistent that goes up with expiration and down with inspiration, and you see that it might not be quite the same variation every time, but you can kind of see it goes up and down and up and down, and you get that really kind of wavy waveform. But to be honest, it's something we look at, but it's not really the thing that makes us decide completely, that this is it's not a significant effusion. No matter how much variation you got with that effusion, you were going to drain it. Really. So so to move on to case 3, which is Freddie. So he's a 3-month-old baby born at term. He's got a few weeks history of cough. He's unsettled when he's lying flat, and he's got poor weight gain. Last few days he's been off his feeds. He's just been quite miserable. Mum can't put him down, and he's now pale. He's got increased work breathing, and he turns up at A&E. He's got a gallop rhythm, he's tachypneic, he's got a large liver, and this is his echo. So does anyone want to comment about what we're seeing here?
So heart failure, I think, due to congenital heart disease.
I was going to get
With some MR as well. MR as well.
So what we can actually see, as opposed to what the diagnosis is that the left ventricle looks very dilated, doesn't it? And the walls are very thin. I mean, they're relatively thin compared to the size of the ventricle. And then, as you said, there's mitral regurgitation as well. So the diagnosis here is dilated cardiomyopathy. And it's just this, horribly dilated, thin-walled ventricle. What's the immediate management? Anyone?
You have to
Do you-
stabilize the heart failure, diuretics, fluid restriction.
Yeah, yeah.
PEEP,
So yeah,
if he needs PEEP.
yeah, absolutely. So supportive, milrinone, diuretics. We want to avoid intubation if possible because these kids are really fragile and anything can just knock them off. And often if they do need intubation, we need to do it with ECMO on standby because they go off, and if they go off, they're very difficult to, get back with just kind of, usual resuscitation. And we always need to think, do we need to be using ECMO? We need to look for a cause. So we have a whole list of bloods and things to do, looking for genetic causes, looking for viral causes. But actually, they're often idiopathic and we don't find a cause. Anyone know the prognosis for this condition?
Or
Yeah.
I mean, I guess it would be cause related, probably like if it's something like a selenium deficiency, you can hopefully sort that out. But I'm guessing most of them require transplant eventually, yeah?
Absolutely. So we always say the rule of threes. And as you say, if you find a natural cause for it, that's a bit different. But, working on the kind of idiopathic thing, we've got the rules of threes, which is a third get better, a third stay the same, but kind of cope, and a third deteriorate to the point of death or transplant. And unfortunately, the problem with transplant in children is that the heart has to come from someone roughly the same size as them. So unlike a liver or, to some extent a kidney, you can't put an adult heart in a young child. So they're really waiting on a pediatric heart, and they just don't come up very often. So we never promise transplant as a way out for these children. And Freddie was only a few weeks old, so it just wasn't an option there. So echo assessment in dilated cardiomyopathy. So we've said we've got dilated, poorly functioning left ventricle with relatively thin walls, as opposed to a hypertrophic cardiomyopathy where you've got very thick walls, and although the function might not be great, it's not got that dilated appearance. Often have microregurgitation as a result of the dilatation. So you want to assess for microregurgitation. We want to assess the function. So we have lots and lots of different ways to assess function. Kind of at the more basic level, we use an M mode. So dropping a cursor through the left ventricle, we can see how the diameter of the left ventricle in diastole and compare it to the diameter in systole and get what we call a fractional shortening. So this is 32, so that's normal. This is obviously not Freddie's heart. It's just a picture I found. Whereas, Freddie and the other children of this, there'll be low single figure fractional shortening. The other thing we can do is what we call 3D, we can do strain. So this looks at the way the heart is pumping, the way that it assesses every single part of the heart wall, and this is showing it in the 3-chamber view, but we also do it in the 4-chamber view and the 2-chamber view to get an assessment all the way around. A normal strain is around -18, -19, so this one is down again. This isn't Freddie. Freddie's strain would be -1, -2 probably. We can use fancy things to do a 3D ejection fraction. So that looks at the volume of the ventricle in systole and diastole, and then we can use 3D programs to show us how the ventricle's moving. And the other thing we need to do with our scan is look for thrombus. So in a very poorly functioning ventricle, there's not a lot of movement of blood, and so it's very thrombotic in there. And you can see in this heart, this very large thrombus is sitting at the bottom of the left ventricle, and obviously the concern is a bit flies up to the brain or into the coronaries and causes a major event. We also need to check where the coronary arteries are, especially in patients between 3 and 6 months old. So the one congenital condition that classically presents at 3 to 6 months with a dilated, poorly functioning ventricle is Al Kappa. So that's anomalous left coronary artery coming from the pulmonary artery. So these babies basically have prolonged ischemia from the point that their pulmonary pressures drop, and then they present very similar to dilated cardiomyopathy, but we find this abnormality, and the surgeons can then replug that coronary in, and these babies usually have a better prognosis than an idiopathic cardiomyopathy, so it's important to pick it up. Right, I do have a fourth case. I'll go through it really quickly just because I need to go to clinic. So Carson, he's 2 weeks old, was born a little bit early and a little bit young. He's presented poorly feeding. He's well saturated, but he's got a murmur and we can't feel his femoral pulses. And his gas shows a metabolic acidosis. He becomes apneic and pale. So he has an echo. And what we can see is just, if we compare the size of the left ventricle with the size of the right ventricle, it's very little. The aortic arch itself is very slender, and then we've got this nipping in here as well, and there's no duct. So what's the diagnosis? This is a borderline left ventricle with a hypoplastic arch. So it's not what we call an obstructive heart lesion. So the blood isn't getting through the left side of the heart. We've got a hypoplastic aortic arch with a tight coarctation, a hypoplastic left ventricle, and no duct, crucially. The initial management was to give lots and lots of Prostin to try and open that duct, because if we can open a duct in this baby, they've got a lot more treatment options. After a night of Prostin, the arch is looking a little bit better. So how Prostin works is it tries to open the duct, but also relaxes the arch a little bit. So we weren't able to open a duct in Carson, but what we could do was relax that really tight coarctation so a bit more blood could get round, which helped him stabilize. So if we talk about echo assessment of left heart obstruction, we need to identify the site of the obstruction. Is it the mitral valve? Is it the LV itself? Is it aortic valve? Is it arch? Or more commonly in kind of hypoplastic left heart syndrome, it's a combination of all of them. Is the LV hypertrophied? You know, you get a hypertrophy LV if it's pumping against an obstruction. And what's the LV function like? So you can see here that this LV function is really, really poor. Is there a duct? So the duct obviously gives a way to supply systemic blood flow in the context of, you know, an obstructed heart. And is there an ASD? And the reason the ASD is important is if, particularly in cases where there's no forward flow through the left heart, all the blood coming back from the lungs gets stuck in the left atrium unless there's an ASD to offload. And the result of that is you then end up with back pressure into the lungs and pulmonary hypertension. And if you're sending these babies down a single ventricle route, pulmonary hypertension is a no-no. It doesn't work. Because what we want to know really from our assessment is the LV adequate to support the systemic circulation? Is the left ventricle big enough? Is the mitral valve big enough? Is the aortic valve big enough? Sorry, I keep saying all these things and then talking. And the other thing is this thing called EFE, or endofibrinoelastosis. So can you see how the pituitary muscles and the edge of the heart of the ventricle are really, really bright? And this is this thing that we call EFE. And this just shows that this is a ventricle that's been struggling for a long time in fetal life. And the presence of EFE is a very poor prognostic factor for a left ventricle to support the circulation. So, sorry I had to fly through that last case, but in conclusion to the talk, echo is a very useful tool to make or rule out a cardiac diagnosis in the acutely unwell paediatric patient, but the patient does need to be tolerant and stable enough to undergo a procedure that is going to take some time. Clinical assessment is essential, and emergency treatment should always be initiated and not delayed waiting for the echo. And that's a picture of Basil, who's my horse, and he's an absolute hero, and he just appears on every single presentation that I do. So you just have to know who Basil is. And that's the end. As I said, I do need to go to clinic, but if there's any quick questions that I can answer, please shout out.
Just one question, sorry to keep you, Sally. Was the TOF case. If I'm in a situation that I'm trying to get the best medical therapy till I get to ECMO, and I'm in a place where I need to start some presses. So I'm assuming you're trying to start some presses, which reduces the PVR along with the prostaglandins. What will you normally go for?
Yeah, so we have on our trust guidelines, but also on our network guidelines, a very step-by-step guideline to work you through exactly what you need to be doing and what point you need to be involving intensive care. So rather than talk about it in detail, if you just Google Yorkshire and Humber Congenital Heart Network and look up the Spelling Fellows guideline, it'll be there for you, and have it available in your emergency departments or whatever, just to guide you through how to manage on these Spelling Fellows. The most important part is, whatever happens, do not give naloxone. If the baby stops breathing because of your morphine, ventilate it. Do not give naloxone, because you'll just end up right back at the beginning, but also now any morphine you're giving ain't going to work. So that's just something to really highlight. But yeah, do have a look at that guideline, and it will take you through all the different steps and everything. Okay.
Amazing. Thank you.
Yeah, I'm going to have to dash, but yeah, great to speak to you all.
Sally, thank you so much. That was brilliant.
No worries.
Thank you.
Bye.
Any questions for Gokul while we're still on the call?
I was just going to mention about diuretics in sinus. In the case with the large pericardial effusion, I was having this conversation where there was a bit of resistance as to why we're not giving diuretics. Is clearly there was some pulmonary edema, clearly tachypneic child, and actually the rationale is that you just don't want to tip the right atrial pressure slightly lower enough that the pericardial pressures just take over, because then you're in a crash situation rather than a planned timed pericardial synthesis.
Yeah, I think that makes sense to me. I mean, there's no reason why, you would, with diuretics, be able to specifically target pericardial fluid more preferentially, is there? So unless your systemic circulation is really well supported, I don't imagine how that would be that helpful. That's just my very simple way of thinking about it. Is that fair?
Totally.
Okay, grand. Well, Gokul, thank you so much for that talk. Both elements of that talk were fabulous. So hopefully for a beginner, it's firmed up a few kind of concepts that people maybe just briefly aware of. And then for someone like myself who doesn't get to do lots and lots of kind of echo in real life on poorly cardiac kids, I've learned loads. So that was amazing. Thank you so much. Big kind of, I'm going to give you some claps for your talk as well, Gokul. So well done. Thank you. So guys, the videos will be recorded and they go on the PEM POCUS UK channel on YouTube, so you can just Google that if you want to watch any of them back. It's